Today I will talk about disaster management as applicable at the hospital level. This is part of my series of lectures on hospital management. This is my lecture outline. First, I will give definition of disaster. Then I will state the classification of disaster. Then I will describe how to calculate disaster risk. Then I will talk about disaster management, pre-disaster phase, disaster phase, post-disaster phase. Under post-disaster phase, I will cover epidemiological surveillance and mental health services. Then I'll talk about general considerations in disaster management and then in hospital disaster management and matrices and KPIs with respect to emergency preparedness or disaster management. So, disaster. Disaster is any occurrence that causes damage, economic disruption, loss of human life, and deterioration of health and health services on a scale sufficient to warrant an extraordinary response from outside the affected community or area. This is WHO classification. Disaster have existed ever since the history of mankind, and disaster have shaped the destiny of the earth and its people. Many of the contemporary disasters have been man-made. So disaster can be classified as natural disaster and man-made disaster. Under natural disaster, we have earthquakes, tsunamis, volcanic eruptions, landslide, avalanches, cyclone, typhoon, hurricane, tornado, hailstorm, snowstorm, sea surge, flood, droughts, locust swarms, and epidemic of diseases. Then, under man-made disaster, we have conventional wars, chemical war, nuclear war, biological war, and accidents which include vehicular accidents, airplane, train, ship, car, drowning, collapse of building, explosions, fire, chemical accidents including poisoning and mine disasters. There are many more accidents which are man-made disaster. Disaster risk is a function of hazard, vulnerability, and coping capacity put together. So disaster risk is equal to natural hazard multiplied by vulnerability divided by capacity of societal system. Now disaster management. There are certain terms. Disaster mitigation include all the measures that are aimed at reducing the impact of a disaster on a nation or community. Disaster prevention are measures which are aimed at impeding the occurrence of a disaster event or preventing such an occurrence having harmful effect on communities. Disaster preparedness aims at measures which enable government, organizations, communities, and individuals to respond rapidly and effectively to disaster situations. Disaster management requires various types of resources at various stages of disaster event, and resources include human resource as well as material resources and financial resources also. Resource inventory of materials, equipment, technical, human skill is a major task of disaster preparedness. Disaster can be classified either as inside hospital disaster or in hospital disaster and outside hospital disaster. And disaster management at the community level is a multi-institutional in its approach, and hence hospital is one of the institution involved. This is for outside hospital disaster. In my present lecture, I will also talk about inside hospital disaster. So disaster management can be divided into three phases. Disaster management during pre-disaster phase, disaster management during disaster phase, disaster management during post-disaster phase. So disaster management during pre-disaster phase. Disasters and mass casualties can cause great confusion and inefficiency in the hospital. Hence, there is a need for hospital disaster plan. Disaster can overwhelm the hospital resources, staff, space, and supplies. Lack of any tangible plan to fall back upon in times of disaster leads to a situation where there are many sources of command. This is important. Many leaders and no concerted effort to solve the problem. So principles of hospital disaster plan include it should be simple and operationally functional. It should be predictable and it should be concise as well as comprehensive. It should be flexible as well as adaptable. It should be anticipatory. It should be part of regional health plan in disasters and it should make provision for vulnerable groups. So the hospital disaster plan is prepared by Hospital Disaster Management Committee. And the members of Hospital Disaster Management Committee include medical superintendent, head of departments of medicine, surgery, anesthesiology, radiodiagnosis, nursing superintendent in charge of support services, security officer, PRO or public relations officer, medical social service department, and engineers. And hospital disaster manual have following reporting, coordinating, recording, and evaluating activities related to disaster management. Hospital disaster management provides the opportunity to plan, prepare when needed, enables a rational response in case of disaster or mass casualty incidents. The disaster plans essentially vary from place to place on the basis of risk, resources, response capability, and multitude of other variables. So it varies from hospital to hospital. There should be responsibilities clearly defined in hospital disaster plan, and there should be a unified command system. As we will see, there should be a command center or command nucleus from where there are unified command released. Then there should be action cards or responsibilities, duties predefined of various staff involved in disaster management. Hospital preparedness is based on risk assessment, hazard assessment, and vulnerability analysis, as we have seen in disaster risk. Type of disaster anticipated based on population and geographical area catered by hospital. This is also important in preparedness plan and preparation of hospital disaster manual. Quick response team roster of medical and paramedical staff should be there as a part of hospital preparedness for disaster management. There should be training of staff and there should be mock drill, which should be at least once in a year. Then there are two capacity assessment methods. One is hospital treatment capacity. It is number of casualties that can be treated in an hour, which is usually 3% of hospital beds time. Then hospital surgical capacity, this is the number of seriously injured patients who can be operated in 12 hours. And this is equal to number of operation theaters multiplied by 7 divided by 4. This is per 12 hours. Then disaster management during disaster phase. Step 1, there is initial alert. So we should note the place, time, and type of emergency. We should also note estimated number and types of casualties, and we should record the source of information, and we should note the callback number of source of information. This is very important. Then we estimate the reaction time, that is time available to prepare emergency room and to reorganize hospital services. Then we activate quick response team. Then we form a command nucleus, which is usually situated in an emergency room. Then we manage the casualties, and casualties are managed, all supported by transportation services, including ambulance, mortuary services, laboratory, radiology, blood bank services, pharmacy services, and operating theaters. There are other services which are very important during disaster management and actual disaster phase. And this include dietary services, sanitation services, laundry services, sterile supply services, stores, water and electricity supply, and communication system. This is very important during disaster phase. So triage criteria, we divide the patients into as critical, emergent, urgent, and non-urgent. So color coding is there: red, yellow, green, and black. So red or critical patients need immediate resuscitation, and these are guidelines. So the guideline include as respiratory rate less than 10 or more than 30, pulse rate more than 100, and not able to follow simple commands. And these patients should be taken care of in few seconds, either in ICU or operation theater. Then emergent cases are potentially life-threatening injuries, and the guidelines include chest pain, dyspnea, abdominal pain, and many others. And these patients should be worked up within 10 minutes in casualty. Then the green are urgent cases. These are usually ambulatory wounded or injured patients, and they are observed in ward within 30 minutes. Then the black category are dead on arrival, and they are sent to mortuary within 2 hours, and they are non-urgent. So this is the figure I have taken from this document. So these are various category of casualties, and this is the flow chart showing either the referral if services are not available in our hospital, or discharge of patient, or death of patient. Next step include media briefing by public relation officers, then post-disaster psychological support, and evaluation of our efforts. Then deactivation. So deactivation should not be too early or too late, and because it is very difficult to reactivate emergency plan after deactivation due to staff fatigue. Then post-disaster phase. Post-disaster phase of disaster management include epidemiological surveillance, mental health services, relief, rehabilitation, and reconstruction. So disaster epidemiologists measure and describe the adverse health effects of disaster. They also measure the factors that contribute to those adverse effects with the overall objective of assessing the need of disaster affected population, matching available resources to need, preventing further adverse health effects. They also evaluate program effectiveness and plan for contingency. So this is the epidemiological data which is usually collected, which include total affected population, age, sex distribution of affected population, identification of at-risk groups, average family or household size, mortality data, morbidity data, nutrition status data, health program activities. Then mental health services include crisis counseling at the time of crisis, emotional first aid at the time of crisis, and the various psychological parameters are determination of thoughts, emotions, level of anxiety, depressive reaction, fear, anger. Then mental health services and psychological care integrated with local delivery system. Then community mental health programs, and there is something known as anniversary reaction. Families report a re-emergence of memories of their emotions with the return of the date of the disaster. Then general consideration on disaster management. It is imperative to adhere to infection control guidelines in the different units of hospital during all phases of disaster management. This is very important. The hospital should have a policy on restriction of entry of visitors, and it is advisable to have separate discrete entry for visiting very important persons, including bureaucrats and politicians. Then hospital networking is very important during disaster management. So network essentially means a dynamic link between various health facilities of a given geographical area. So various hospitals, they network with each other to help management of casualties during disaster. Then information management is very important aspect. This include communication and record keeping. So it is a role of command center to effectively coordinate the hospital preparedness and utilize the hospital networking for disaster victims. Furthermore, proper documentation of disaster victims in the hospital is necessary for identification purposes, need assessment and impact assessment, as well as for compensatory purposes. Usually government, they provide some kind of monetary compensation. So it is very important for proper record keeping. And now brief about in-hospital disaster. So various steps include alarms stage. So it is the pressing of disaster alarm from the source. Then emergency classification of the in-hospital disaster, and this include red color for fire, orange color for disaster, then cardiac arrest, then missing child or uh, absconding child or abduction, then violence, bomb, evacuation. So these are various emergency codes. Then various actions taken include turn off the lift, then evacuation of patients and personnel from the source, opening of fire exit, direct the patients to use it, shift the bedridden patients to nearby safe zone, and the sequence of evacuation should be patients in immediate danger, ambulatory patients, semi-ambulatory patients, non-ambulatory patients. So this is the sequence which should be followed. And other actions include in case of fire, depending on the nature, extinguisher should be applied. Then hospital security team should control the crowd. Police and fire force should be informed by security officer and turning off of power supply to the source if needed. Then finally, hospital management is responsible for passing the message to press and media. And once all the patients have been evacuated, all the staff should leave the source. Then, when situation is under control, we announce code green. Then finally, briefly about various matrices and key performance indicators in disaster preparedness as well as the disaster. So individual preparedness, I have taken from this article. So the factors include knowledge, disaster emergency plan, information and communication. And these are the indicators. This is actually a very interesting article and readers are referred to this DOI, digital object identifier of the article. Then we can take some matrices from annual mock drills. That is the number and type of mock drills completed, staff participation rates in mock drill, and any lessons or improvement learned from the mock drills. Then matrices can be emergency preparedness matrices, which include number of organizational departments in charge of emergencies, then amount and variation of crisis communication plan, the number of preparedness initiatives and number of trainings and facilities. Then emergency response, which is usually measured by mock drill matrices, as I have described in my previous slide. Then emergency recovery matrices, these are related to recovery processes. So this is further reading. There is a publication by WHO on emergency response checklist. So this is all for today. Thank you very much.